And we look at the way that occlusion comes into all of this. There are several different approaches to occlusion. What I was taught in dental school was stuff that was based on skull studies from 150 years ago. And looking at a skull, it makes sense that the condyle fits within that fossa and it works like a ball and socket. And so we have this hinge, and we even talked about it as being a barn door hinge. That's not how it works. That's not how our patients are built, but that's what we were taught. And so when we look at our approaches to occlusion, what's the difference between what we typically do day in, day out in most dental practices and what the occlusal philosophies are all about? When you look at the occlusal philosophy that has the science to support what kinds of decisions are being made, not convention, but science, what actually says, yes, this objectively backs up what you're doing? That's neuromuscular dentistry. That's one of the powerful things about it. When you look at neuromuscular dentistry, neuromuscular occlusion, we look at the hinge axis basis for centric relation. It's based on the idea that the hinge is there somewhere in or right around that condylar head. Posalt himself, when he designed Posalt's envelope of motion, even says that we function better slightly in front of centric relation. The man who designed the parameters over how we function and helped us all to understand what that envelope of motion is was ignored. The H line in the middle, the curved line with the little X on it, that's physiologic function. That's the line along which we function, not anywhere on the border. There's no place on the border with the exception of centric occlusion, which may or may not be physiologically correct. Every place else on the border is a manipulated movement, and Posalt himself says that we function slightly better, slightly in front of centric relation. So when we're looking at this, it's not about the articulations of the bones in the joint, because that's not how it works. That lower jaw is suspended by a sling of soft tissue, muscle, fascia, ligaments, tendons. All of that stuff works in concert together to support the lower jaw. That's the reason that if you have a patient that's had a motor vehicle accident or cancer and you have to remove the condylar head itself, you remove the condyles, that patient can still function, because the joint in the body isn't the condylar head to the glenoid fossa. The joint in the body is tooth to tooth. The joint across which we function, when you put a Big Mac in your mouth and you chew it up, the joint across which you function isn't a bone-braced position, it's a tooth-braced position. We bite and chew molar against molar, not condyle against fossa. So when we're looking at how this works, the muscles have to play a role. So we've got to make a decision. How do we want to set up our patients? By convention, because we are taught to do and then reinforced with insurance parameters, reinforced to do dentistry one tooth at a time, we build our cases one tooth at a time. So we do most of the dentistry that we do in centric occlusion. But we have options. If a patient's in a pathologic bite and they're paying a price for it, you could either put them into a manipulated centric relation position, whether you do bimanual or chin point, or you use some kind of arch tracing system or whatever method you want to use. You can put your patient in a manipulated centric relation position. Now, the real honest truth behind where centric relation came from is it was a record-gathering tool. It gave us, in removable prosthetics, a way to create a repeatable record. That's it. It's a repeatable record. It never said that it's physiologically correct for your patients. We made that the reality for centric relation. We started to assume that because it's how we built our cases. But that's not why we put them in centric relation. We put them in centric relation because we could take the same records every step of the way when we're making complete dentures. We put them in centric relation because it's all we had left. We didn't have any teeth to mount against. We didn't have any teeth to take a bite against. The patient would close together until their nose and chin touched, so we had to find something different. That's what the bone brace position is about. And that's not what our patient's physiologic position is about. So that gives us our other option, neuromuscular dentistry. How can we take a physiologically designed muscle-based position? And how do we do that? When you get muscles on your side, you got a lot of things going for you. When you look at the neuromuscular occlusion and some of the symptoms that we talk about with our patients, there's a whole host of things. The symptoms would be things patients come in complaining about. TMJ pain, noise, headaches, neck pain, back pain. These things hurt patients. They can't swallow. They've got facial pain, pain behind their eyes, things like Bell's palsy, trigeminal neuralgia. You've got things that make the quality of that patient's life worse, and the patient knows it. Those are symptoms, and your patients are going to complain about them. They would be willing to fix them if they only knew that you as a dentist could fix that. But they rarely will ask us about it because they are trained by our profession to only think about dentistry as being related to the teeth. They don't think about pain behind the eyes or pain in the ears or numb fingertips as being a dental problem. And they don't think about it because we don't ask them about it. If we asked our patients these kinds of questions, We would be blown away with how many of them are dealing with it. The numbers are 80% of the people walking around are dealing with a pathologic bite. Now, it's less than ideal. It's suboptimal. Are they paying a price for it? Not all of them. As a matter of fact, only about half of them are even having symptoms. So about half the people who have a bad bite are suffering some kind of a consequence, and about half of those are in pain. So it's about, it's about 20% of your patients who are walking around day in, day out who are having pain and looking for answers. But 80% of your patients are in a less than ideal bite. So what we're talking about is helping to design an approach in your office so that those patients that walk in complaining of these symptoms can be heard. And when you start asking these questions, they will start telling you stories that you never imagined were going on in their lives. You never imagined it because we never knew to ask it before. You look at the common signs, there's a bunch of common things that we can see. Red flags, things that you should be looking for in every one of your patients. Crowded teeth, big red flag. There's something wrong. The teeth aren't in the neutral zone, and so there's an imbalance in force between the tongue and the orbicularis and buccinator muscles. Missing teeth, that starts that domino effect. It starts a lot of problems. Fractured teeth. Why are the patients fracturing their teeth? In absence of decay or restorations, there's no reason for a tooth to chip. Why do teeth chip? Why do restorations chip? Why is it that the patient's having these problems? When you look at collapsed arches, when you have a normal arch shape, it's like a big fat wide U, lowercase letter n. When you have a patient who walks in with any other arch shape, is it square or is it a V shape? Does their mouth look like it's a dog's mandible? If that's the case, there's something going on. Your patient's tongue doesn't have the home to live in. Your patient's airway is being challenged by it, and we aren't trained to recognize that. That's one of the things we need to be looking for. Wear facets on teeth. What does it mean? Where do they come from? Why do they happen? Wear facets are from that patient trying to find a better home base. They're trying to find a place for their micro-occlusion so that it can meet and support the jaw-to-jaw macro-occlusion that's right for your patients. Well, if you've got wear facets, they're fighting that micro-occlusion position because it's not correct. Most of the time, they're not going to be able to grind into a position that's better because as you grind your teeth and clamp down, all you're going to do is close further. And most of the time, the issue is they're already closed a little bit too far anyway. So what we want to do is design a way that we can help our patients to see what's right. When you look at common symptoms, it's things like headache or neck pain. You've got back pain. Lower back pain is something that we're not even really thinking about as dentists, but it happens that a lot of the patients with lower back pain have a dental problem. And if we fix the dental problem, we can support a more comfortable life for them and get rid of the back pain in the process. Joint pain, and this can be in the joint in the neck, but it can also be in the joint itself, the condyle. And then forward head posture is a major, major issue. If you think about what ends up happening in your patients, if they're in a bite that's overclosed, then that lower jaw has closed up and back too far. And as it does that, it takes the tongue up and back. As it takes the tongue up and back, you've got two choices. Either you're going to kick your mouth open and the tongue's going to come forward, or the tongue's going to go backwards. If it goes backwards, it occludes the airway. If it occludes the airway, the patient can't breathe. In the ABCs of first aid, the very first thing that you get is airway. Field trauma in the Marines, it's start the breathing, stop the bleeding, protect the wound, and treat for shock. The very first thing you do is you get your patient's airway opened. Well, it's the prime driver for you. Airway is king. And if your patient's airway is occluded by the tongue, they've got no choice but to accommodate for that. So if the tongue doesn't stick out of the mouth, creating an anterior open bite or bicuspid drop-off or some other issue like that, then the tongue's going to go back and it's going to create a pinch in the breathing tube. It's going to create a bend in their snorkel. And in order to fix that, just like Breathe Right strips would open up your nose, what your patient can do is they can stretch their head out and it opens up the airway, but now they can't see where they're going because they're looking up, so then they bring their head forward. And now they're in this forward head posture because it's the only way they can breathe. But it's not right for them. And because they're in a bad muscle balance position for their head, the muscles in their neck, the muscles in their back have to hold not a 10-pound bowling ball, but a 30-pound bowling ball off center and keep that patient from falling over. It creates a lot of problems. And so we need to be able to make that diagnosis. Give our patients the opportunity to decide, is it worth the effort for me to get this fixed? Because a lot of times it is. There are patients that don't even know they need to have anything done. They don't know they've got an issue. This patient came in and he's asking for whiter, straighter teeth. He wants something like Invisalign and Zoom whitening. Whiter, straighter teeth would be great, but his teeth aren't that crooked. Could they be straightened more? Yes, but would it really do what he needs to have done? Fortunately, when he came in, one of the girls on my team was really on her game, and she was paying attention to what kinds of things he was asking about and what kinds of things dentistry can do, and gave him the chance to explore ideal dentistry. That's what he looked like with his biggest smile that he could muster, the absolute biggest smile we could get. You can't even see what color his eyes are. You can't see his teeth. You can barely see that he has teeth. So is he in a proper physiologically based, muscle comfortable, bite comfortable macro and micro occlusion? Not at all. But he wasn't having any symptoms. Now it turns out that we went through the process, and as I've mentioned before, you first dial the bite in plastic, and you get that bite settled into, based on a plastic orthotic, a more comfortable position, something that we think makes more sense for the patient, and you prove it out over time. As it turns out, after wearing the orthotic, he got dramatically better very, very quickly. He started to actually sleep better. He was fixing problems that he didn't realize he had. And then we restored him from where we started into a bite that actually made more sense. And in the process, you can see not just his teeth, but also his eyes. And so looking at the difference that it can make is it's really just about helping to explore what's right, prove it out first, and then make the long-term changes. Look at some of the other things that we can do, what we do for our patients. How can we help our patients to see what's possible in dentistry? And you'll have a lot of patients that will come in and they'll be looking at dentistry as just this necessary step. And they don't see things like self-image and self-worth. As a matter of fact, the chairman of our department had said that you can't change a person's psyche by changing the shape and color of their teeth. And that couldn't be more untrue. It's such a huge part. They say the smile is the window to the soul. It's absolutely true. When we meet people, based on psychological testing, they've looked at what you look at when you meet somebody new. And of course, we glance all over the body, but we keep coming back to three things. We keep coming back to the two eyes and the mouth. And so when we meet somebody for the first time, how the eyes and the mouth relate to each other is a giant part of how we see that patient. And that in return, as we carry ourselves through the world, how we feel our face is in balance between the eyes and the mouth is a giant part of how we carry ourselves. Now this girl, fantastic girl, but was trapped behind her smile. Through life circumstances that were just an absolutely horrible thing, she ended up, over a period of a couple of short years, almost dying, but in a set of teeth that didn't fit who she was inside. Now, she fixed the part that almost killed her. She changed the lifestyle that she was living. She got out of an abusive relationship, and she got her life back on track. But she was trapped. She was wearing the scars. She was wearing these reminders, and she wasn't who she should be because of it. She was still trapped behind that smile. And what we did was we walked through the process with her, and went step at a time. We ended up fixing the bottom teeth too, but changed her from this person who didn't like who she was and didn't like how she carried herself into a person who did. And she had every reason to. She's one of my favorite patients that I've ever had because she's such a great person inside and out. What was holding her back was her teeth. She felt like somebody that she wasn't because her teeth kept reminding her of something that she didn't want to be. We fixed that for her, and it changed everything about her life. There's another patient sent this email. At this point, she wasn't a patient, but she says, I don't know if you can help me or not, but I have to try. I've always been unhappy with my teeth, and I want to get them fixed. I've seen a dentist here, and he sent me to an oral surgeon and orthodontist. They said they could fix me, but it'd take surgeries and years of ortho. I've seen too much reality TV to know that there has to be another way. I hope you can help me, or maybe because I hate my teeth. I've attached photos so you can see my teeth, and I have clay models if that will help. I hope you can help me, or maybe know someone who can. Now, when I got this email, I lived in Oklahoma, right in the middle of the state, and she lived out in the Panhandle, so it's a 3-4 hour drive each way. And I didn't know if I could help her or not. I also got this photo that came along with it. When I look at that photo, what I'm guessing is that the midline is right down the middle of one of those teeth, and it looks like that's a baby tooth in the bottom, and things are kind of all over the place, and I don't know which tooth exactly is missing. I don't know if I can help her or not, but we invited her in and we took a look, and that's what we ended up seeing in her mouth. And you notice the color of the contacts that she's wearing. It's obviously to draw attention away from her teeth. She actually asked for stupid white teeth. That was her term, stupid white. But you can see that she's wearing these crazy blue contacts because she's trying to distract you from something that she doesn't like about herself. And I know she doesn't like that about herself because you look at pictures of her. When she's taking a photo with one of her friends that has pretty teeth, you can't see her smile. When she's taking a photo with a friend who doesn't have the prettiest teeth in the group, she does actually smile. It's amazing what people will do. She didn't know she was doing this. She didn't realize she was hiding her smile, but anytime she's in a picture with friends that have pretty smiles, she didn't smile. That's not fair. That's not the right way to grow up. She is in college, putting herself through school, and is trapped behind her smile. Now, what happened for her is we ended up helping her to get into a smile that really works. We fixed the aesthetic things that were holding her back, and she sends this other email. Today I went to my first and only dentist that I've ever been to, the one who wanted me in metal forever. Now, obviously he didn't, but that's just the way that she wrote it. He was so surprised. I had him and the staff in tears. Why do I always have that effect on people? Everyone is always crying around me. He said to tell you good work and told me he was very happy for me, like everyone does. It's been how long now? Since January 24th, and these kinds of things still happen every single day. I always see someone I haven't, or an old acquaintance, teacher, etc., and thank you again for everything you've done. And then she sends this photo. What a cool thing it is to be a part of that. I didn't change who she was. I changed how she felt about who she was. I took down the barrier that was holding her behind. And when you did, it did some amazing things. It ended up that as we got that fixed for her, we changed her smile from where it was into something that made more sense. Not only did she graduate on the Dean's Honor Roll, she was homecoming queen. She ended up getting into Cinderella pageantry in her town. She ended up getting on a life mission to take Cinderella pageantry to small town America. It changed the course of her life, and she says it's because of me, and I had very little to do with it. All I did was get rid of the barrier that was holding her back. Now, of course, not every patient needs to be a full mouth rehabilitation. As a matter of fact, some of the most fun cases that we do are not full mouth rehabs. I had a patient who, his wife swears that I saved their marriage, and all we did was 8 teeth. He had bicuspid drop-off, and it happened to match the difference in his bite. And when we restored his 8 posterior lower teeth, 7 of them had failing restorations in them anyway, so there was 1 tooth that we made a little different shape in order to get it to the right spot and support the right bite. It ended, for him, almost 18 years of chronic headaches. He didn't have headaches from time to time. He had varying levels of headaches. For all of his life, from the time he was 13 until I met him, he had headaches. And his wife thought that the headaches that he had were related to her. His headaches weren't because of her. When he had a headache, it's because he had a headache. And it was affecting their marriage. It was affecting how she felt about herself. And what we did was we put him into the proper bite. And we used CAD/CAM technology and then supported that proper macro-occlusion with long-term porcelain and fixed his headaches. And it fixed their marriage. I didn't expect to do that, but what a cool thing as a dentist to be able to do.